You are listening to Walking Home from the ICU. We will be exploring how to save and preserve lives in the ICU. All opinions and views shared are unaffiliated with any organization. Dr. Badke, thank you so much for joining us.
Thank you for having me.
Tell us a little bit about your career path, what your experience has been, what's led you to be here now.
Okay. Well, so I am trained in pulmonary critical care. I did my kind of medical school training at the University of Washington, and then I went to Chicago at Northwestern and did internal medicine residency. And then I did fellowship in pulmonary critical care at the University of Utah. So I've seen different kind of hospital environments and different kind of ways people take care of critically ill patients. And ultimately, I ended up here primarily just because I like Utah a lot. And, after fellowship, I wanted to kind of stay in clinical medicine. And this provided me a kind of a good resource to continue taking care of patients, but also kind of have kind of an academic, or at least kind of, more of a research-based approach to kind of taking care of patients. So,
and you've been such a great fit for our team, but it was probably a little bit of a change or transition, as it is going anywhere new. What were some of the changes that you saw, and what was that like to have a shift of perspective?
Yeah. So, I mean, I think, like I kind of alluded to earlier, I think every institution kind of does things a little differently. And obviously the culture has some influence on that. And I think in regards to kind of managing patients on the ventilator, I certainly have seen kind of differing kind of approaches. I remember in residency, the usual order set was, get the patient intubated and then start a fentanyl and Ativan drip, together. And then, once you've kind of resolved their kind of septic physiology or whatever they're being intubated for, you would then kind of stop the sedation and kind of see what happens.
And what usually happened?
Well, sometimes when patients would kind of wake up and, we would, at that point, they could have been probably extubated earlier, but they'd wake up and then we'd just kind of pull the tube out. Sometimes, certainly people would be super anxious and, we'd have to give them more sedation to try to kind of get things calmed down. Often it ended up, like I said, I think people were intubated longer than they needed to be. And then when I started fellowship, those drugs specifically were becoming less used, and we were using more Propofol with kind of as needed fentanyl. That was kind of the usual kind of cocktail. And generally you would intubate somebody, put them on a Propofol infusion, and the same thing, kind of wait till their physiology improved. And then, each morning you do this kind of SBT, where shut Propofol off, see what they did. If they were awake and, improve their kind of respiratory kind of mechanics, then we try to extubate them. So that was certainly kind of what I did up until kind of coming here. And then when I came here, Propofol is rarely ever used in kind of ventilated patients. And sedation in general is kind of avoided, which is certainly a kind of a cultural change that I hadn't seen before necessarily.
And what was that like for you? Did it concern you?
I think not necessarily that it concerned me. I think what was more reassuring was the staff was not concerned. I think a lot of, from the, physician or critical care physician perspective, sedation was more an issue of whether the nursing staff and the kind of day-to-day kind of staff taking care of the patient how they felt and whether they felt comfortable. And often kind of sedation was driven by, hey, this patient's out of control. Let's can we get something for, sedation essentially. And, from my perspective, I didn't necessarily mind ordering that. But avoiding it, I certainly felt like was probably better. And here, seeing how calm the nursing staff was, and the culture kind of just revolved around kind of avoiding sedation, and everyone kind of knew that, it made the whole process a lot better, I think. And from my perspective, I thought would be, I was a little surprised just with that. And then, the mobility aspect of what we do here is also kind of more than I was used to.
What had you seen across the board before this?
Well, I guess so. In things kind of have evolved, just like sedation has evolved. I think in residency, there was always maybe one or two patients on the unit that somehow magically was able to survive with the ventilator off sedation. But the majority of the patients were, asleep or whatever, sedated. And then in fellowship, certainly kind of mobility and physical therapy became, a higher priority. And so we had more staff to help out with that. And with that, people were getting less sedation. And then, here, at least when we kind of really focus on mobility and getting people walking as soon as they're on the ventilator, it's made a big difference, I think, for patient outcomes too.
What was it like the first time you intubated someone here and then asked?
Yeah. So one of the kind of standard things, is, at least in fellowship, was, you would be putting all the orders in. So you get the patient intubated, and then you put the vent orders in, and then with that, you put in sedation orders. And I often would just kind of ask the nurse kind of what they wanted. And so I did that here, and I said, do you want, should I just order Propofol infusion, some as-needed fentanyl? And they just kind of looked at me like I was crazy and said, no, we don't use Propofol here unless we, they just said we don't use it here. And so that was kind of surprising. But kind of, makes me realize you don't necessarily need it. And again, I think it's just goes back to the comfort level of the staff here when it comes to kind of managing ventilated patients.
Yeah, I think culture plays a huge role in that. And I too walked into this culture. I didn't have to work on building it. It just was already here, and it's continued.
Yeah.
Once you see, then there's no going back. It's hard to then choose to sedate people when you've seen how much benefit there is to them being awake and mobile.
Yeah.
What have you seen in patient outcomes that's been impressive to you?
Yeah, I'll see some of these patients in clinic, from a pulmonary perspective, if they have bad pneumonia or ARDS. I've seen some of them in clinic, and they're remarkably functional. Obviously, they're not back to kind of what they were like before their illness, but certainly they are living kind of independent lives and doing remarkably well, considering how sick they were.
Do you see a lot of them able to go back to work?
I think so, or at least some form of work. It may not be the exact thing they were doing beforehand, but sometimes it just depends on kind of the job they were doing. If it was a very physical, kind of intensive job, they're not back to there. But certainly they are kind of at or close to kind of getting back to where they were before they got sick, which I think is important.
Yeah. Do you ever ask them about PTSD?
I personally haven't. So no.
Yeah, I think that's probably kind of a new direction that we're starting to head, but it's all new research.
Yeah.
What was it like to see someone that you just intubated walking on the ventilator?
Well, I think, again, it kind of shows you going through training, it was, again, the people, there was just a very rare kind of, person that could tolerate the ventilator without being sedated. That's what my thought was, that like, it's just, certain people can tolerate the ventilator, certain people can't.
Mm-hmm.
And now kind of, as we're, within this environment, it looks like everyone can tolerate the ventilator, and, walking them is even better, in terms of kind of helping their anxiety and kind of normalizing the situation as best we can. I think that's what walking, or at least mobility, does, is it kind of normalizes, the situation for patients. Just like, the ventilator, while can be uncomfortable, shouldn't necessarily impede, just like a nasal cannula. It doesn't necessarily impede kind of function. So I think that, again, as my kind of training kind of has kind of evolved, that's become more and more of a everyday kind of thing. And now it is an everyday kind of thing.
And so as a physician working with this really cohesive team, what do you feel your role is in this protocol of sedation and mobility, and improving patient outcomes in the short and long term?
Well, from my job is not really that, I feel like, influential. I really do think it's driven by kind of the comfort of the nursing staff, the physical therapist, the respiratory therapist. And my role is more kind of supportive. And obviously kind of making sure that there are kind of medications available for anxiety and analgesia if we need them, but to focus on not necessarily sedating people, but to keep them as functional and as alert as possible. So again, my role is more to kind of enforce that, but not necessarily. I really think the staff here is what really kind of makes the change.
Yeah, I feel the same way. But having physician support and making those changes and continuing this little bit of a rogue or different kind of protocol has made a huge difference, and it's empowered and comforted the staff to continue on doing things that are different. So thanks for all your support and your awesome role in the team.
Oh, thank you.
Thanks, Andy. If you want to join in on the conversation, leave a voicemail at 801-784-0472 or reach out to me on Twitter.